lecture. I just supplemented with some of the journals I read. So let's start this with a case. This is a 68-year-old hypertensive woman with acute consciousness disturbance, gaze deviation to the left, to the right, bilateral limb paralysis on the fourth day after aspirin prescription. So I'm just showing you a eggshell DWI image revealing a acute bilateral MCA internal border zone and right posterior border zone infarcts. So the case is a watershed border zone infarcts. So what is a watershed border zone infarcts? These are ischemic lesions involving the junction of the distal fields of two non-anastomosing arterial systems. This constitute approximately 10% of all brain infarcts, and there are different causes, but conventional theory implicates hemodynamic compromise produced by repeated episodes of hypotension in the presence of severe arterial stenosis or occlusion. Border zone infarction may be better explained by invoking a combination of two often interrelated processes. Number one, hypoperfusion or decreased blood flow, which impedes the clearance of emboli or washout. Severe occlusive diseases of the internal carotid artery causes both embolization and decreased perfusion. So border zone infarcts are grouped into two main categories based on their location. The external or cortical border zones located at the junction of the anterior, middle, and posterior cerebral artery territories, while the internal or subcortical border zones are located at the junctions of the anterior, middle, and posterior cerebral artery territories with the Hübner, lenticular striae, and anterior choroidal artery territories. So just showing you the vascular territories here. So infarcts in the anterior external border zones or the cortical border zones and paramedian white matter is in between the anterior and middle cerebral arteries, while the parieto-occipital or the posterior external border zones are in between the middle and your posterior cerebral arteries, while the internal border zone infarcts are in between the lenticular striae in middle cerebral artery, lenticular striae anterior cerebral artery, and the others. The infarcts of the lenticular striae middle cerebral artery are the most commonly seen in imaging. And with that, and knowing that we can discuss the differences between the anterior cortical, posterior cortical, and internal watershed infarcts. So in external cortical border zones, microemboli from the heart or atherosclerotic plaques in major arteries may preferentially propagate the cortical border zones, which may have lower perfusion than other areas of the vasculature, and thus a limited ability to wash out these emboli. So in imaging, these are usually wedge-shaped or ovoid, and usually shows a better prognosis than the internal internal border zones. Better because in the external border zone, these are closer to the cortical surface, where penetrating arteries originate, and thus it has a better chance of developing collateral supply through the leptomeningeal or dural anastomosis. In the figure, we can see the coronal fluid attenuated inversion recovery images showing distribution of the external cortical border zone infarcts at the junctions of the anterior and middle cerebral artery territories. Another image of the DWI-ADC showing bilateral posterior cortical border zone infarcts, which corresponds to the vertebrovascular system disease. The anterior external border zone infarcts are more common than the posterior ones because of the high prevalence of the internal carotid artery disease. For internal border zone infarcts, this usually appears in multiples, a series of 3 or more lesions, each with a diameter of 3 millimeter or more, arranged in a linear fashion parallel to the lateral ventricle in the centrum semi-ovale or spora radiata. It usually has a rosary-like pattern or rosary bead sign. Just another image showing another multiple internal border zone infarcts in a rosary-like pattern along both corona radiata. Usually tends to localize in the paraventricular regions, and as I said before, is a poorer prognosis rather than the external. So this is just a MIP image of a CT angiogram showing you a healthy volunteer volunteer, which shows the probable location of the internal border zone. So I'm just showing you this image, just a review. This is an eggshell flare image showing you wedge-shaped areas of cortical hyperintensity in the left frontal and parietal lobes, and foci of deep white hyperintensity in the parasagittal distribution corresponding to the external and internal watershed regions. In the DWI shows restricted diffusion, which indicates acute infarcts. So these are the watershed border zone infarcts. For my next case or topic, I'll be discussing this patient. This is a patient admitted with eye complaint, detached retina, and underwent surgery. 24 hours into admission, complaints of dizzy spell, and 14 hours later had seizure episodes. So in the first 24 hours, we see a small focal parenchymal abnormality at the left parietal occipital junction, and a dense and large left transverse sinus. So after 14 hours in the same area, we see an acute focal hemorrhage at the gray-white matter interface of the left parietal occipital region. So this is a case of a venous infarction. So what are venous infarction? These are an uncommon form of stroke and most commonly secondary to cerebral venous thrombosis. They frequently manifest with hemorrhage and does not correspond to typical arterial territory. Symptoms are non-specific. Some reports headache, sudden focal deficits, and often seizures. They occur in children and young adults and tends to be rounded in shape and spares the overlying cortex. Causes are usually due to direct involvements of the dural sinuses like infection, trauma, neoplastic infiltration. Possibly with damage to the vascular endothelium, venous stasis, hypercoagulable states, and increased blood viscosity. It is important to know the venous system because cerebral venous thrombosis is located in descending order in the following venous structures. So the most common it would be the superior sagittal sinus. Next would be the transverse sinus, then the straight sinus and sigmoid sinuses. I will be showing you the imaging findings for venous infarction. Direct signs of CVD are uncommon and are seen in only 1/3 of cases. Direct visualization of thrombosis in dural sinus may give a dense clot sign, which in this eggshell non-contrast head CT in a patient with meningitis, there's demonstrating subtle increased density within the right transverse sinus, as you can see here by the arrow. In the next image, CT venogram in the same patient demonstrating feeling defects within the right transverse sinus, confirming the diagnosis of sinus thrombosis. So in this contrast enhanced CT scan, I'm showing you the empty delta sign. This is a triangular area of enhancement with a relatively low attenuating center, which is the thrombosed sinus. Due to enhancement of the enriched dural's venous collateral circulation surrounding the thrombosed sinus, producing central region of low attenuation. Sometimes only secondary signs of cortical swelling and infarct are apparent on non-contrast CT, raising the question of venous thrombosis. The earliest sign of venous infarct is gyral swelling, which is often extremely subtle and only appreciable by noticing the effacement of the adjacent sulci. So in this first image, we can see an eggshell CT scan showing cortical edema on the left superior frontal gyrus, causing effacement of the sulcal space. Superior sagittal sinus is also hyperdense from thrombus. On the next images, there's reduced diffusion from infarct with cortical edema and swelling in the left superior frontal gyrus, as pointed by the white arrow. There's also a region of hemorrhage with susceptibility GRE within the anterior portion of the swollen and infarcted gyrus. Another finding, as we can see in this eggshell CT scan, there's parenchymal cortical hemorrhage in the right temporal pole with thrombus in the torquilla, seen here by the black arrow, and thrombus of the right transverse sinus that mimics a temporal subdural hematoma. So going back to our first case, we need to understand that cerebral veins are thin, valveless structures that do not contain smooth muscle. So venous infarcts occur due to obstruction of the venous system by thrombus or external compression. Venous pressure continues to rise, leading to cortical edema and the appearance of vasogenic edema on imaging, then overcomes the arterial inflow pressure, ultimately leading to cytotoxic edema that exacerbate the degree of venous obstruction, leading to a cyclical cascade of edema and further cerebral venous obstruction. Usually, hydrocephalus may occur in the early phases due to decreased cerebrospinal fluid absorption, contributing to elevated intracranial pressures. And ultimately, if unable to withstand the pressure, it leads to parenchyma hemorrhage. And that's all the CT imaging for venous infarction. Thank you. For my questions, number one, which of the following images depicts a watershed border zone infarct? Does anyone want to answer?
C.
Sir, JV, is this you?
Yes, Padam.
Yes, that's correct. C. As you can see, there's the rosary-like pattern, rosary bead sign in the centrum semiovale. Letter A is the left MCA infarct, while B is a chronic ACA left infarct, but indeed it's an intraparenchymal hemorrhage. Number two, which has a better prognosis for the two types of watershed border zone infarct? External or cortical zone infarct, B, internal or subcortical zone infarct, C, both or none of the above. Anyone? Okay. The answer is A. This has a better prognosis because the external border zone is again closer to the cortical surface where penetrating arteries originate, and thus it has a better chance of developing a collateral supply through leptomeningeal or dural anastomosis. And for the last question is, where is the most common location for cerebral venous thrombosis? This would be superior sagittal sinus. Next would be transverse, the straight and cyclic. Thank you.
Thank you so much, Dr. Andre. You have carefully explained about the cerebral venous infarction, and that ends the four-part series about ischemic infarction. So I have no further additions to the current topic. I would like to open the floor for questions and comments for our reporter. Okay, if there are none, I would like to thank everyone for your time in participating in this morning's FDR session. Good morning, everyone, and have a good day.
Thank you, Doc.